Now we received a couple of questions in the chat, and I want to start with Wim. Wim, you said that there's a parameter that could get an impression of the platelet numbers and the function, the PCS. So could you explain again what is the advantage of PCS compared to platelet count? That is the standard in most of hospitals and even in urgent situations.
Overall, we see a good correlation of PCS with platelet count, but we have seen many examples where, so if you take 800 data points, you get a nice regression line, and that sort of gives you an overall impression what you can expect with respect to platelet count and a certain PCS values. But there are many cases, and that may depend on the clinical context, where the PCS value is actually lower or higher than the platelet count. In cardiopulmonary bypass, for example, we see this, or in ECMO, platelet count can be low, but the platelet function can also be affected. And if platelet function is more affected, is more diminished than platelet count, your platelet count may give you a false impression of what's happening, but you do see that in PCS, which is then much lower than you would expect based on the platelet count. COVID-19 is a clear example of the other way around. Platelet counts in COVID-19 are, most of cases, within the normal range. We see very few thrombocytopenias, and there are very few thrombocytosis where you have high platelet counts. But if you look at the platelet function, they are very hyperactive, hyperreactive. And it's also what we see in PCS. The PCS is extremely high and doesn't really match with the platelet count, which is normal. So the PCS is sort of integrating both functionality as well as amount. And I have the impression that it may give you overall a better indication of what's happening in the patient than only looking at platelet count.
I want to add something. I had this one case that you probably remember with the aortic tube grafting who had a very low PCS count. Mm-hmm. However, the platelets were perfectly normal. And this was the patient.
Or the platelet count.
The platelet count was normal. Yeah. Perfectly normal, but PCS was very low. Yeah. And this was the patient who was taking quite a high dose of anti-steroidal drugs, and we treated him with desmopressin, and after that we really stopped bleeding, and you could see the PCS going back to normal.
Yeah, well, that's again explaining this, because the platelet count didn't change, but the functionality was improved, and there is literature on this. It's known that desmopressin, well, it's pumping up Wilmot factor, but it's also doing something on the platelets. It's making them more procoagulant, and that is reflecting in the PCS, which was then increased. So the PCS is catching a lot on the platelet functionality and not just the amount of platelets.
So, I mean, the challenge is that most of physicians are thinking about the platelet function, but they only see the platelet count in a lab result. So, most of the time we just say that it's identical, but it is definitely not. Exactly. So, Jung, as you said, you treated a patient with desmopressin. So, as far as I know, there are no data, but what would you think? Would this be an option in the future to identify patients with platelet dysfunction using these point-of-care testing and to avoid?
Well, I wouldn't generalize. I think in specific patient, like this patient who was on antisteroidal drugs, or patients with von Willebrand factor, where we absolutely know, especially in type 1, desmopressin works very well. This would be an indication. You can't generalize and say all patients would benefit from it. But if you take a close look at the patient, have a history, medical history, there are some cases, like in this one, who really profit from it.
Wim, you showed slides about fibrinolysis and trauma patient, and you provided data of the recent study, trauma patients, about 70 or 80 patients, and you said that fibrinolysis was rare. As I remember, 2 or 5 patients, or in total 7 patients, showed hyperfibrinolysis. So, and this is interesting as the recent published iTactic study, also focusing on point of care testing, showed some beneficial effects and a trend, but no significant beneficial. And this might be the problem, that the percentage of patients with initial coagulopathy and initial hyperfibrinolysis is probably not so high, and the advantage of point of care testing is probably in the next step. So it's not the initial period after trauma. What would you say?
Yeah, looking at the literature, fibrinolysis may be rare on the machine. On the other hand, there is also, based on the CRASH study, most trauma patients may already get tranexamic acid, even in the ambulance. So that's another reason why you may not see it. But maybe monitoring is another important aspect. So maybe they get hyperfibrinolytic later, or maybe you need an additional dose of tranexamic acid. So there may still be some value there. Another important discussion topic in the literature is to look at different phenotypes of fibrinolysis. So there's not only hyperfibrinolysis, there is also fibrinolytic shutdown, a phenomenon that we also see in COVID-19 and has also been shown in trauma. And in those patients, tranexamic acid may even be detrimental. So there's still a lot of research, I think, to be done, but the whole area of fibrinolysis is complex and it's emerging. So it's not one single phenotype. You have hyperfibrinolysis and you have fibrinolysis resistance. It may be important to also distinguish these phenotypes to better guide management.
So this again is emphasizing the concept of a patient individual concept. So it's not that we just give tranexamic acid and coagulation factors to every bleeding patient. It really needs a diagnosis before a therapeutic approach. Jürgen, you also said you provided excellent examples of bleeding patient, bleeding situation, and how you treat them and how you improved bleeding management. But there was also a patient where you could say, at least retrospectively, there might be some type of over-treatment in terms of coagulation factor substitution. So what would you say? Is this again an example that we need more diagnosis, more monitoring in parallel to treatment?
I think Quantra is very useful in the setting. If you correlate clinical bleeding to the results that you get from Quantra. In this case that you mentioned, we probably overtreated, but it was so dramatic, the bleeding. We run 2 or 3 tests, one after another, but the bleeding was so massive that we couldn't even wait for the short time that Quantra shows us a result. So in this case, we also did not only treat the patient with antifibrinolytics, but also gave him fibrinogen, because the test we ran before was on the somewhat lower end of fibrinogen. So we assume that with continuous bleeding, consumption of factors, hemodilution, this patient probably needed some more fibrinogen. And then when the last test was through, we saw that patient really stopped bleeding at this time, and then we saw that it was probably too much of fibrinogen.
What is your opinion on the key question, why is point of care testing still not standard of care in any bleeding patient?
I think one is anecdotic. I mean, we are working with standard lab values. They're still even used for evaluating patients preoperatively, although we know that a PTT or PT doesn't give you any hint of the occurrence of bleeding intraoperatively. So this is somewhat anecdotic things that keep going on. And I think the second issue is that, as I said, POCT is not reimbursed, at least in Germany, is not reimbursed in the first place. We have the DRG system, and it all goes into one case. If you use it or not, it is not reimbursed. And this is a problem for many of the providers, I guess. I think it will change in the future because it's so useful. But financing POCT is an issue, I guess.
What would you say, what is necessary to improve implementation, to improve use of point of care testing 24 hours, 7 days a week in the situation of a bleeding patient?
I think this is education. I think this is getting the message out, how useful that is, and that this is really the only possibility besides lab values that can't really help you in this situation, that you have a very close look on coagulation and what is going on.
Mm-hmm. And based on your experience in your hospital, how long does it take to get to know to this new technique and to have an idea at what time or what indication and how to use it for treatment?
I know that Wim can also answer this question because they did a study on that to get the, I think, FDA permission. From my experience, that was very quick. You get a very sound understanding of the machine if a technician explains it to you in about an hour, and then you just run the test because they're really easy to run. You take a 3 milliliters probe, put it in the machine, scan the patient's ID code, scan your own ID code, and then run the test. And even after 10 minutes, you have the first results when you look at the curves. So that was quite easy. But Wim, you could also answer this question.
Yeah,
because
the study we did was on request of the FDA as part of the regulatory clearance procedure. The study was called the reader study. So it was really focusing on interpretation and reading the dials and understanding what the dials mean and how to act upon it. So an audience of 20 or so anesthesiologists with various levels of expertise, so from juniors until seniors, were given a training of 30 minutes on the dials and what the dials mean, how to read it, and what you can do with it. And then they were given a multiple choice test with cases. And the pass rate was more than 95%. So the level of understanding was very quick and the learning curve was very, very small. Yeah.
Then you showed data about and the difference between the baseline and 2 weeks of COVID-19.
Yeah.
You showed that the clot stiffness went down.
Yeah.
Do you have an idea if this was related to any drugs or medication like anticoagulants, or was this?
It was a small study. It was published by Ranucci and did a small study. It was 20 patients or so, but they were treated with anticoagulants, but more than a standard prophylactic dose. So they were more aggressively treated with anticoagulants, and they also had 1 or 2 patients with elevated platelet count, thrombocytosis more than 400,000, and these were given antiplatelets, clopidogrel. So it's a combination of clopidogrel and therapeutic dose anticoagulants. Now, there is a big issue, a big debate on how to treat these COVID-19 patients. So all guidelines now say you have to at least give prophylactic dose, low dose, but maybe you need to treat some patients more aggressively. Now, based on what? So that is being debated, and it's not clear yet who will benefit from therapeutic dosing. Some of the recent trials seem to suggest that if you are in the ICU and are severely ill, it can even be detrimental, and it's probably only beneficial in patients in the wards. So we will see in the near future what all these randomized trials that are ongoing, what they will tell, what to do with respect to antithrombotic dosing in patients with COVID-19.
When we saw the data and the numbers and the dials, how do we know that these are the normal values or the standard? Do you have some background information? How do you define what is a reference and what cutoff do we have?
Yeah, so the dials that we showed you with these nice green bars, the green bars are what we call the normal reference range. Now, that is a rough indication. It is based on a study in normal healthy individuals done in the US, so normal healthy population of 120 individuals, 60 women, 60 males, with a nice distribution according to age. These are default settings. You can change them if you want. If you think that in your population the values may be different, you can change that. But a normal reference range, of course, is different from a transfusion trigger that you may use in a patient. For example, a patient may have a normal healthy individual, an FCS value, fibrinogen contribution across stiffness value of, say, 1 hectopascal. close to 1 gram per liter may still be good. The patient is not bleeding because it's normal, but in a situation, cardiac surgery, for example, or trauma, that can be detrimental. So hemostatic reserve in a normal healthy individual is different from a patient in a trauma situation or under heavy surgery. So the transfusion trigger needs to be chosen in the clinical context. And that requires further studies to validate that. So far, we have done that based on equivalency values against ROTEM and TAG, where there is evidence in the literature. Algorithms are being published with ROTEM and TAG, for example. So we can sort of translate these published transfusion trigger values into equivalent Quantra values, but we may need further validation studies, true interventional studies, to see how that also pans out with the Quantra. But a lower upper limit of normal is not the same as a trigger value in a clinical context. So these are different things.
Jürgen, one next question. What would you recommend? How often should these type of tests should be done during treatment of massive bleeding? I mean, this situation could be dramatic, and source control should last 1 or 2 hours, and bleeding management. So what would you say? How often should these tests be done in the context of massive bleeding management?
I think it really depends on the clinical situation of the patient. What we always do in either emergency surgery or in huge surgery, if there are extensive cases, we do a baseline test. And then we just look at the patient and see how he's doing. If we have any hint on ongoing fibrinolysis, or if the patient starts to bleed, we run another test, and we see how the patient develops and how the tests develop. So it really depends on the individual patient. We don't have a scheme where you say every half hour we run a test. I think this is not really cost effective, but if the patient, at least when it starts to bleed, we do this, and we usually in the bigger cases we start a baseline test.
Any final comment, final conclusion, Wim?
Well, I hope that this session has convinced the audience that a good, reliable, easy-to-use point-of-care system is a key tool in the patient blood management armamentarium. And as also Dr. Lutz showed from his practice, it gives you valuable information to improve patient management. So, and from Paul, it was also clear that education is an important hurdle and a stumbling block. So with systems like the Quantra, I think the learning curve, as we discussed, seems to be very, very, very small, and people can quickly understand the dials. So education is a key thing indeed, and there is lots that still needs to be done, but there is a huge place for good, reliable, rapid, easy-to-use point-of-care systems in the patient blood management programs.
Yeah, it gives you a lot of security. If you have a point-of-care device right at hand, right next to your patient, you don't have to wait for lab values that you're not really sure about what they tell you about the ongoing bleeding. And as Wim told, and I'm very happy that 66% of all the participants said that is educational aspect. It is a very educational tool to learn more about coagulation and to see how what you get, how it correlates to the bleeding situation.
Okay, so thanks to both. Thanks very much for your excellent, brilliant talk, for the data, for the details that you have provided. Ladies and gentlemen, thank you very much for your attention to this workshop, to the questions that you raised. And patient blood management is so important to improve the care of our patient, particularly in the situation of any uncontrolled bleeding, in any unexpected coagulopathy situation, to get an impression what is the underlying problem. There are so many factors and reasons why patients might have a bleeding situation, starting by medical history, drugs, platelet inhibitors, We talked about tranexamic acid. We talked about coagulation factors. We talked about coagulopathy because of dilution in the situation of massive bleeding, massive transfusion. So please keep an eye on your patient, particularly in the situation of uncontrolled bleeding, and do diagnosis before therapy. So stay healthy. Thank you very much for your attention.